May I introduce you to our next speaker, Dr. Rob Buist, as an assistant professor at Muscle Metabolism University in Amsterdam from Netherlands. He's going to talk about skeletal muscle function and post-exertional malaise in patients with long COVID. Thank you so much for being here. When you're ready, you can share your screen. Thank you so much.
I need to change this. I think you can see my screen, and you should also be able to hear me.
Yes, it works fine. Thank you so much.
Correct. Thanks a lot for the introduction, and thanks a lot for the organizers to organize this conference. As a Dutch-speaking contributor of this conference, I have to mention something about the origin of the conference, as a tribute to the many very severely ill patients with ME/CFS or long COVID. That include, for instance, Laureen that we've seen before, but also Anil that we saw before the session. And particularly Laureen, she wanted to become a journalist and a writer, and I think it's good to mention that that from her words resonated with me when I prepared this presentation, that tell the world about this terrible disease and that no one should be lying in bed behind the closed doors. The important thing that also I think is super important for us scientists and also people working in this field is that we need to listen particularly to the patients, because they have the most experience with disease symptoms and the pathophysiology. And that's how also our work in this field started. Because we received a phone call from a clinician in the local hospital, a local Amsterdam medical center that sees a lot of patients with ME/CFS. Michelle van Vught, she called me and said, well, there is something wrong with these patients. They are super fatigued. They cannot perform exercise. That actually worsens their symptoms. You as a movement scientist, how can, in a muscle with expertise on muscle physiology, how can we help and better understand these patients, what they have? So we started this project about 2 years ago, and we started off with a bunch of colleagues and particular students who work on in this field, who wanted to work in this field, who did their internship with us. So we started very low, and gradually this got momentum over the last years, and now we're here. So just to give you a little bit of information, I'm an exercise physiologist, and I'm particularly interested in the fact that post-exertional malaise occurs in those patients. Post-exertional malaise, to recap, this particular key symptom of long COVID as well as ME/CFS is the worsening of general symptoms such as brain fog, cognitive problems, but also muscle fatigue, and also other parameters, general symptoms related to long COVID that happen within 48 hours. Can happen very early, but also there is sometimes in some patients a delay in this after physical, cognitive or mental exertion. As an exercise physiologist, I particularly focus on the physical exertion, the exercise. We need to remember that this all happens above a patient and time-specific threshold, so that can determine the severity of the disease, but also that can change over time. And we know from experience that post-exertional malaise can last for days, weeks, or even months. So this is a specific symptom of the disease that is very not understood, essentially, particularly because we always think that exercise is good for you. But if you look at the amount of patients that suffer from this particular symptom, post-exertional malaise comes as one of the top 2 symptoms in patients with long COVID after general fatigue. And what I want to do in this talk is to see whether the changes that we see in the skeletal muscle and the function of the patients, whether we can separate out the pathophysiology of general fatigue from that of post-exertional malaise. As I mentioned before, the dimension of post-exertional malaise are such that intensive exercise is not the typical medication that we think, or we thought at least beforehand, and still think in some cases for patients with long COVID and ME/CFS. And that is a tricky thing that the balance that people have to deal with on a day-to-day basis. If they go over that particular threshold, they get a remission and this development of post-exertional malaise. So that's something that is very uncommon, that we don't see in any other disease, general chronic disease across the board. Patients with diabetes, heart failure, but also people with depression and also other cognitive problems.
Sorry for interrupting, Dr. Wüst. Can you switch to presenter mode because your slides are small, please? Thank you very much.
No, sorry. This way I should do it. No, wait. Now it should work. Correct?
Wonderful. Thank you.
Perfect. Sorry about this. So indeed, exercise is not the typical medicine that we see for patients with long COVID and ME/CFS. And that's what you also see in this typical figure from a nice video, online video on ME/CFS and PEM, post-exertional malaise. At one moment, a patient may look perfectly fine, but the next day, after seeing a doctor, this can turn completely, the patient can look completely different. An important thing for the disease is that there is no blood or imaging biomarker available to detect post-exertional malaise. So whether someone suffers from post-exertional malaise, one of the key symptoms for the disease, we cannot measure that in blood or other imaging modalities. And as such, there's only the questionnaires are available to get the diagnosis right. And this is the DSQ PEM questionnaire. This is the 10-question questionnaire where you can detect whether your patients in the clinic or yourself may suffer from post-exertional malaise. It's important to realize that not all long COVID patients suffer from this post-exertional malaise. So if you look at persisting symptoms after COVID-19 infection, there are various groups of patients essentially that can be regarded as typical long COVID patients, such as patients that are hospitalized and may suffer from deconditioning, malnutrition, but also muscle wasting and systemic inflammation, just simply due to the hospitalization after the acute COVID-19 infection. Older patients, but also patients with comorbidity, also tend to have long-lasting problems after a COVID-19 infection and may therefore not be the typical long COVID patient that we look for. And we really, like early on, we highlighted that there's a specific subgroup of patients that suffer probably from viral persistence that we've seen before, immunological changes, microclots that will be discussed in the next presentation by Dr. Pretorius, but also suffer from this specific symptom post-exertional malaise that I'm going to talk about in more detail. So earlier on this year, we published a paper that received a lot of media attention about the muscle change that we see after induction of post-exertional malaise in long COVID patients. So I will walk you through the general results of this publication and also provide a broader perspective of the meat of the findings. So what we started is an idea that post-exertional malaise is generally diagnosed on a 2-day exercise test. So you do first an exercise test to see how well the exercise capacity is of the patients, but then you also induce post-exertional malaise, and the next day you ask the patients again to go on the bike to see whether they reach the same levels essentially as before. And then you say, okay, someone has post-exertional malaise. But that also means that you need to do 2 times an exercise test to the maximum, and therefore you probably really worsen the post-exertional malaise of the patients, which is not what we want to do in patients. So instead of a 2-day exercise test, we opted for a 2-day muscle biopsy test and blood measure tests. So what we did is we performed, we took muscle biopsies as well as blood samples a week before an exercise test, and then we asked the patients back at 1 day after doing the exercise test, where we studied the whole body exercise tolerance, as well as to induce post-exertional malaise. And we followed up to 7 days with blood measurements and other questionnaires. And these biopsies were taken in the free time and in between other surgeries by our very skillful team of surgeons here. I mentioned Jelle and Frank. So it's important to realize what patient characteristics we have. So all patients were diagnosed with long COVID based on interviews and medical history, which includes the criteria that they had to suffer from post-exertional malaise and 3 months persistent symptoms. And we didn't want anyone who was hospitalized after COVID infection and other comorbidities. Here you see also in the table the amount of patients, and the control subjects, healthy controls, the sex and ages were similar. Working hours were very different between the two groups. Patients before the COVID infection worked 36 hours, but now only could work 5 hours a week. There's also an important thing that while we do see that the amount of steps per day is less in the patients, in the red graphs on the right hand side, we do not see that they're completely bedridden. So we first focus on the exercise measurements that we performed. Here in figure A, you see the maximum oxygen uptake consumption of these patients. And you see a very wide heterogeneity in patient characteristics. So some patients had a relatively okay maximum oxygen uptake consumption on the bike test, while they still suffered from post-exertional malaise. So some patients were ex-professional athletes, for instance, that participated in our study, and they still had a reasonable exercise tolerance. If you look at the power output, it was also significantly reduced, and the gas exchange threshold, which is a marker for where the problems reside, were reduced as well, suggesting that there was already the first hint that there was something going on inside the skeletal muscle. So when we looked further in the skeletal muscle measurements, we focused our attention first on the low-hanging fruit, as we call it, is the fiber type distribution. Is there something that obviously explains why these people are more fatigued? And if you look at a fiber type distribution, you can have white fibers and red fibers, and white fibers are fast fatigable fibers, and those are the type 2 fibers. And the type 1 fibers are more red, and they provide you with long-lasting energy, and with that you can exercise much longer. You can run, for instance, a marathon with that. What we spotted is that on average, the patients with long COVID had a lower percentage of type 1 fibers and a more glycolytic or more fast fatigable fiber composition, as we see in the type 2X and type 2A fibers. So they're more white fibers. If you look at the power output that a patient could attain on the bike, what we see is that for a given cross-sectional area of the muscle, they could attain actually lower power output on a bike in figure F. But also what we spotted very early onwards is that the mitochondrial density as a marker here on the x-axis in G is that it didn't relate to the maximum oxygen uptake consumption that we measured on the bike. As we would normally expect in healthy control patients, we see a nice relationship between the two. That relationship was completely absent in the patients. That suggested to us that there is something else happening on top in these patients that were related to the production of energy in the mitochondria. So we focused on the next slides on the metabolic changes that we see in the patients in the skeletal muscle. So here you see the metabolic and mitochondrial changes that we observed in patients, and they worsened particularly after reduction of post-exertional malaise. So we measured the energy production independent of supply of oxygen. So the oxygen supply to the mitochondria was more than enough, was more than the limitations. So there was no problem with the perfusion, so to say. We really isolate the mitochondrial function itself, and we see that there is a lower amount of ATP production availability in the patients compared to the controls. But that also worsened after one day after induction of post-exertional malaise. If you look at the mitochondrial density in B, we do see not so many differences at rest, indicative that there is something intrinsically wrong with these mitochondria, but that particularly after the induction of post-exertional malaise, we see that there is a difference occurring in the patients. On the right-hand side, we did some metabolomic measurements in these patients, and you see here that particularly the pathways related to ATP production or the ATP synthesis in the purine synthesis, as well as in the TCA cycle, the tricarbonic acid cycle that relates to the ATP production, they were mainly more blue in the patients, which suggested that they were lower in the long COVID patients. And they also tend to be more affected one day after post-exertional malaise. So the easy explanation that we had back in the days was a microclot theory that was ongoing about 2 years ago when we started this project. So the idea was, okay, there are clots observed in patients, and Dr. Pretorius will talk a lot more about this in the next presentation. And they may be able to clot the capillaries, to reducing the flow to the tissue and as well as the skeletal muscle. So we turned our attention to these microclots to see whether the idea that would block capillaries is true. So we stained for these amyloid-containing deposits, or the microclots, using the THT staining that's typical for this type of work, and we do see that these microclots are inside the skeletal muscle. We also see that there are more in the patients compared to the controls, and also that they go up after. One day after the induction of post-exertional malaise. So we do see that there is a reason that there is something happening with these microclots with post-exertional malaise. However, we didn't spot them inside the capillaries. You see on the bottom images on the left hand side, you see the long COVID patients where in green the THT measurements, the microclots are stained, and in pink you see the capillaries. And you see that the green and the pink image.
Dr. Wüst, I kindly ask you to come to an end. Thank you.
Yeah, I will do that. So that they are not inside the capillaries. We also spotted that the muscle had a lot of muscle damage markers and infiltration of immune cells. And this is something that we follow up now, and we wanted to see whether this also occurs in patients with ME/CFS. As a follow-up on the previous presentation about the viral persistence, we do see also N-nucleocapsid protein, part of the virus, inside the skeletal muscle of these patients, as well as the controls, but it doesn't change so much after post-exertional malaise. So just to give you some background of responses to ongoing discussions we've had with colleagues. We do need have smaller groups, but I have to say that this is logistically, ethical, very challenging to induce PEM in patients. I do need to mention that physical inactivity is not suspected to be the underlying reason for these changes that we see, and we can talk about it during the questionnaires. Physiotherapy is therefore not directly the answer to these to improving fatigue and post-exertional malaise in patients, but as long as you don't go over the threshold, that may be part of the general therapies. And I think the bottom the conclusion slide is here is that I really wanted to separate out the contribution of the reduced exercise capacity in patients and those two post-exertional malaise, where we see really rapid changes in the metabolic systemic changes in the metabolism and markers for muscle damage and infiltration of immune cells. Future work, we wanted to study this with ME/CFS, of course, and really highlight the contribution of physical activity in patients with ME/CFS and long COVID. Linking it also with endothelial dysfunction microglots. Together with Dr. Pretorius, we do this. We try to also to do more general work, linking it to sort of daily life activity in patients with heart rate variability, whether that can be used as a marker for and predictive for PEM. And what are the acute changes that occur directly after exercise. So as a last slide, the take-home messages is that many patients with long COVID and ME/CFS suffer from PEM. That we peripheral changes in blood and muscle can help to explain fatigue and muscle pain, but we don't know the underlying X factor for this, and that the skeletal muscle alterations after strict bed rest are completely different. And importantly, exercise above this PEM threshold is counterproductive for recovery, and that is patient and time dependent. And the last slide is, I think, the most important one. The team that helped all this and all the research support that we've received over the last year to do this work. Thank you very much for your attention.
So thank you so much for your presentation, Dr. Wüst. Very interesting. So we are now continuing with the Q&A, and the first question is, the muscle weakness is often interpreted by doctors as deconditioning. Is there a scientific way to distinguish these two?
Yeah, that is indeed the case. Deconditioning is often seen as the main cause of this. We do a lot of work in bedridden patients together with ASA and NASA, and we see completely different phenotypes essentially occurring in bedridden patients compared to patients with ME/CFS or long COVID. So I do think that the changes that we see in bed rest and in deconditioning are different from those in patients with long COVID or ME/CFS.
Okay, thank you. So next question, what can we do to maintain muscle function with long COVID?
Yeah, that's a good point. And I mentioned that at the very end here, is that the physiotherapy and ergotherapy particularly can help to make sure that you do not go above the time and person-dependent threshold to induce PEM. And I think that's a very important. So pacing strategies are important for daily life function of patients, and making sure that you are aware that when you go over that threshold, that you reduce very quickly afterwards and keep below that PEM inducing threshold. That's currently the only advice we can give to patients.
Okay, thank you. So we have time for another question. Your study did not seem to measure lactate levels. Many long COVID patients report raised lactate levels. Do you see a role for disturbed lactate metabolism in long COVID, or do you think it is not relevant?
Yeah, this is a very good question. The lactate that we measure is at maximal exercise, and that was not different between patients and controls, which suggested that indeed at maximal exercise, lactate is similar between patients and controls. So that is actually confirmative. What we do with our metabolomics measurements, I'll try to go back here. These measurements are all taken during rest, and also there we do see a reduced TCA cycle intermediate, so metabolites related to ATP production. And particularly in the glycolysis, we see higher levels of glycolytic metabolites. Lactate, however, is an end product, so we add, and during rest as well as maximal exercise, this is not so informative of what happens inside the skeletal muscle.
Okay, thank you. So another question, fatigue in long COVID somehow feels like exhaustion of energy and not like any post-workout body weariness I was very familiar with before. In your opinion, should we consider PEM in long COVID as reinforced typical fatigue, or rather as some new molecular mechanism unique to long COVID or ME/CFS conditions?
Yeah, this slide, I think, highlights it very nicely. I think the general fatigue feelings of patients with long COVID can be attributed to more generic structural changes in the body. But what happens with PEM is that there is a specific symptom that triggers something on a very rapid basis. And that, I think, is different to the general feelings of fatigue. So I think the contribution of the reduced exercise capacity, which is the general feeling of fatigue on a day-to-day basis, can be explained by structural changes in the muscle and also probably other parts of the body. But there's a very specific trigger for post-exertion malaise, so that the molecular mechanisms are likely different between the two.
Okay, thank you. So, and one last comment from the chat. Thank you for mentioning Anil and Lauren.
Welcome.
Somebody mentioned. Okay, Dr. Wüst, thank you so much for being with us, for presenting your latest research and insights. And we go on with our next